Welcome to the latest in our series of TopMedTalks 2. In these podcasts, the TopMedTalk team is in conversation with global thought leaders in perioperative care. TopMedTalk.
Hello, I'm Desiree Chappell, and this is TopMedTalk. I'm here with Monty Mythen, editor-in-chief of TopMedTalk. So we now have the opportunity to sit down with a very special guest, Dr. Amir Jaffer. Hello.
Thank you, Desiree,
Hello.
and thank you, Monty, for having me here this afternoon.
Yeah, absolutely. So Dr. Jaffer is the chief medical officer for the New York Presbyterian in Queens, and you also happen to be the founding director of the Perioperative Medicine Summit. Thanks again for sitting down with us. It's always really important to TopMedTalk that when we're at meetings, we can talk to the people that had a hand in developing the particular meeting. And the summit has been really unique. This is my first time here.
Great, welcome.
Yeah, thank you. And I am a CRNA by training, and so this has been great. I mean, this is right up our alley in anesthesia.
Maybe when we're
sure.
done, we'll talk about how best to recruit CRNAs.
That's right.
It's a challenge in the country.
It is. I know everybody. I've been hearing someone was talking about in Florida how they just can't get any CRNAs down.
It's the weather.
I don't know, but it's been fantastic. I love that we sit down at 8:00 and the first thing you hear is this awesome update about what is happening in our world of perioperative medicine. It was very powerful and great.
I think that the update really helps the audience to really hear about all the latest studies in the area of perioperative medicine that probably will impact care.
Yeah.
So they like to pick a lot of references that will have an impact on care. And Steve, Barbara, and Paul go back a long time, and they're a nice trio to be.
Yeah, they are. They work really, really well together.
Yeah,
it was really good. You can see the dynamic, chemistry there. Right?
Absolutely,
that's good. Throughout the whole meeting, I think what's really neat about it too is that it gets everybody pumped up and excited for what you're going to be learning, because you get all this and then that translation of, okay, this is how you actually take it into practice and start using it.
Exactly.
Yeah.
Exactly.
And was that whenever you started the summit? Is that kind of what your vision for?
My vision and Frank's vision was, how do we get everybody in this space together, right? The anesthesiologists, the internists, the advanced practice providers, the CRNAs, everybody together, and have them hear about the latest evidence, but make it very practical. So bring in speakers who have expertise, but also who are involved with managing patients on a day-to-day basis. And that's how this symposium or meeting got off the ground, is because we brought in the best speakers, but we also got in people who were very knowledgeable because they were either produced guidelines or research, and then we had the cutting edge evidence base to share with the audience.
Yeah, and everyone's so passionate about it,
Absolutely.
what they're talking about.
I think we've really created a very, very unique community now, right, in perioperative medicine. And that's what this meeting has really helped foster, in my opinion.
Yeah, I love it. Monty, we were listening to Amir's presentation today, and what kind of struck you as some of the things that were...
Well, it's in your new role, as I understand, Amir, as a chief medical officer, so responsible for the delivery of many of these things, but broader than that. There's a couple of things I just wanted to pick up on. One of them was respect. And I think I heard you right. You, in your institution, now have a chief respect officer.
Oh my gosh, I wrote that down too.
What's one of them?
Yeah. So,
where do you get them?
When I started at our organization about 2 years ago, I came into, I don't know if you know much about New York Presbyterian, but New York Presbyterian came together about 15 years ago. New York Hospital and Presbyterian Hospital got together. We have 2 Ivy League medical schools, Cornell, Columbia. And so the organization, New York Presbyterian, was made up of 2 different cultures. And then over the last few years, they've acquired more hospitals, including the hospital that I'm at, which is now called New York Presbyterian Queens, but used to be called Booth Memorial and then New York Hospital Queens. And this is the new name. So when I landed here, I started to learn more about all the transformation that was happening. And the really senior leadership, our CEO, Steve Corvin, our Chief Operating Officer, Laura Faris, felt that we had a problem. We had a problem with respect in the organization. And so they really worked with the frontline employees to put together this respect credo. It was on one of my slides today.
Yeah.
And the bottom line is that every role, every voice counts, right? That's the fundamental premise of the respect credo. But it's an amazing document if you get a chance to spend more time to read it. That was the beginning of really our journey in the whole transformation in the culture, but starting with respect, because the leaders felt that if we don't have respect, we really can't do anything. You can't have teamwork if you don't have respect, and you really can't do the things that you really need to do in healthcare, because healthcare is really a team sport.
Yeah.
And so we started there, and then we basically took it to the front lines, and we talked every single day about respect. We took examples of respect that employees would come up and talk about, or disrespect, that they'd been disrespected. By talking about it every single day, then we had a major employee retreat at New York Presbyterian Queens a year later, which was also focused on respect. And now the enterprise, which is 40,000 employees, decided very recently over the last couple of months that they would have a chief respect officer. If you don't have respect, you basically can't do anything, right?
Yeah.
So, what is the chief respect officer? What powers do they? How do they? Let's imagine someone's acting up and just won't show respect.
Yeah.
It's deep in their DNA to be a pain in the whatever.
So I'll just tell you that even before we appointed a chief respect officer at our organization, we were well underway on this journey. And so when reports of disrespect got up to our leaders, they had the ability to actually remove and fire individuals.
You said that during your presentation.
Yep.
I was amazed.
Yep.
Wow.
And
it works. I mean, it
works. It works.
Yeah. That's so interesting.
Can I have another one?
Yeah, of course.
You went values, credo, and then huddles.
Yeah.
Tell us about your huddles. They're not cuddles, but they're huddles.
Absolutely. So over the last year, we've been on a lean journey, but nobody knows that we practice lean. So what I mean by that is our leadership decided that a lot of people get intimidated by a lot of these Japanese words around gemba and so forth, right? And they decided, well, what do we really want? We want leaders to be visible, transparent, out there with their employees, observing how things are going, giving them feedback, giving them coaching. But at the same time, we needed a structured approach to get information up to the leadership, so we can break down silos, we can make sure resources are available, figure out where the challenges are, so we can get involved as leaders. But you need to build that relationship with your employees to share information, because oftentimes employees feel intimidated to share information with their supervisors. So we, again, approximately a year ago, we started this journey of putting into place 3 tiers of huddles. The first tier is the tier 1 huddle, which happens at the unit level. And at the unit level, you have clinicians, nurses, doctors coming together at the unit level. They have a huddle board. They have a structured approach. They just spend 10 or 15 minutes sort of huddling together and reviewing all sorts of information, perhaps information from overnight. But they have 2 huddles a day now on every unit. And then from there, that information is fed up to the directors, which we call their tier 2 huddles. And then the directors bring that information to a leadership huddle that occurs at 10 a.m. every day. We basically have a board, and we basically have very structured information that we go through. It's about 50 plus elements that we gather information on. But for each element, it takes no more than a couple seconds. And you could be red, green, or if you have issues with staffing or with flow, or, for example, the elevators broke down last night, or there was a water leak. A lot of that information gets circled up here at the huddle, and then people who are accountable for each of those areas have to then give an update or status in terms of where they are with addressing that. And then the following day they have to say whether it was resolved or not. Some problems, get resolved within hours, and some within minutes. Some take a longer time. But regardless, we keep it there, and we talk about it in a couple of days if it's still not resolved.
How long do you allocate for it?
It's usually 15, 20 minutes.
Do you do it standing?
Yeah, well, half the people are standing. People who come earlier grab seats. But it's usually no more than 15 or 20 minutes. The other part, Monty, is that we always end with recognitions. And we always start with overnight safety events and good catches. So, talking about the transformation that's needed to get to zero harm, we want to recognize people who actually identify problems before they affect patients, right? Before the problem, in fact, hurts a patient. If people identify a problem, that's considered a good catch. And we actually give them a pin to recognize them.
So you actually award people for doing the right thing when normally you would probably feel intimidated in most organizations.
Right. And then at the end, we always identify situations where people have gone above and beyond, and we recognize them openly. So it's really started to this culture where things are transparent, where people feel like things are fair.
Safe zone, too.
Exactly. They feel comfortable speaking up, and just the positive reinforcement has also helped create a really nice culture.
I'm guessing that 15 to 20 minutes standing cuts out about 5,000 emails.
Yes, I have to tell you that definitely we don't get a lot of emails around these issues because they get solved in real time.
Wait for 10 o'clock. And just get
it all out.
Get it done.
I definitely feel it's great. It's really, really helped the communication.
One more question on the huddling. Do the huddles that take place on the rock face on the floor, do you do them in public? Or do you go to a private room? And the reason I ask
the ones on the floor? Yeah. Well, no, it happens right in the unit.
Yeah, so patients. Perfect.
So usually, you have patients who may be walking by. If the patient actually happens to be walking in the corridor and there's a huddle going on, if they want to observe, they're welcome to observe. We usually don't take patients' names and stuff. If we need to, we ensure nobody's around.
I think that's a very positive step as well.
Transparent, yeah. I love this theme, though, that for everything that you've been talking about is getting employees, your team involved from the bottom up, top down. Because so many of these initiatives, they come from the top, but they don't do anything with the people that are actually the ones that are having to communicate and having to, do the change themselves. And so, I think that's such an important part of transformational change and change management.
Absolutely.
That gets forgotten.
Absolutely. Like you said, you got to make sure that the front lines are involved in the change. You hear from them. And, what's really, really striking, exciting about the huddle is that anybody who's there can speak up afterwards to recognize their peers. And then we go down every item. So whoever is the lead for that area, will speak up and tell us if there's any issues, and they usually say red or green as a way to signal if things are good.
Yeah.
You showed us. Drew a graph out here. It's not a great radio shot, that one, but it's this extraordinary graph of the inverse relationship between surgical site infections and safety culture score.
Yeah.
So if you have a very high safety culture score in your organization, you have very few surgical site infections. Did I get that right?
That's right.
That first graph that I showed you was actually a paper from 2016.
Yeah.
That was not from our hospital.
Oh, okay.
That was 7 other hospitals, and that was a different publication. The second graph I showed was from our organization. But really, I think there's more and more evidence that suggests that if you in fact improve the culture of safety, your outcomes improve. Yeah. Because I think it's all about the teamwork.
Of course.
If you have great teamwork, then you actually can deliver great outcomes, know?
Oh, absolutely.
And what's the safety culture score have in it? Can you remember some of the elements?
So the culture of safety, there are different surveys out there. As you know, the Agency for Healthcare Research and Quality has a validated instrument. There's another instrument that we've used in our operating room called Pascal Metrics. I believe that's the name of the tool that's being used in the OR. And a lot of these tools have been validated. But the questions are, for example, for the Agency for Healthcare Research and Quality, for the AHRQ, they have questions such as how do you perceive the leadership? Are they transparent about safety? How do you feel the culture is? Is it punitive or not?
That's huge.
So there's a lot of great questions. I can certainly give you more details of those questions if you like.
So one last thing I've written down, if that's all right, Desiree, is
please.
You were asked about your cancellation rates for surgery.
I love that.
You reported that it's quite high.
Very high.
If I can paraphrase what you said, the sooner you fall behind, the longer you have to catch up. It was my old adage at school, in other words.
No, our rates are terrible, 7%. But I have to be honest with you. When I started the chief medical officer, we had so many other issues and problems that this went lower down on my list of priorities. Mm-hmm. But now that I've been there over 2 years, this is a deliverable this year.
Great. But I'm sorry to interrupt, but I think you implied the fact you don't have a pre-op clinic.
We have a preoperative clinic now with advanced practice providers, but I don't think they have the level of supervision and the expertise that they need. The system is not where I'd like to see it to be. So what I've been telling our leaders is our preoperative clinic is called PRAC, Preoperative Risk Assessment Clinic, and I tell them we're now going to be moving towards PRAC 2.0, and that's the plan for this year. And I think that's going to hopefully help us get the outcomes that we need, which is hopefully a cancellation rate of less than at least 2%.
Because we talked about this often on TopMedTalks. In the NHS, we're about as mean as you can possibly get with money. So we it's really unlikely we would do anything unless we were certain it was value for money. And as far as I know, we've got complete preoperative clinic coverage in the whole NHS and have done for a very long time. So it's kind of like slam dunk. What's the disconnect there? Because you're not the first person we've heard. I think Lee Fleischer told us they don't have
one, yeah.
The issues are there are multiple stakeholders. In the national health system. You don't have a lot of private physicians. I mean, you do have private healthcare in the UK, obviously, but in the United States, you have a lot of physicians who are private practitioners, and historically, our healthcare system has really incentivized volume over value, as you know. As a result of that, in a lot of these healthcare systems, the referring physicians or the primary care physicians want to do their own preoperative evaluation. So it's tough to try to consolidate it, especially if you're a community hospital with a large number of private medical staff. But I think we're nearing a point where we all want to do what's right for the patient. And what's right for the patient is making sure that they appropriately optimize. And I feel like there's so much variation when multiple groups are doing it. But if you can bring it together with standardized algorithms, hopefully we can get the appropriate outcomes.
Thank you so much.
Thank you for having me, Monty and Desiree. It was a pleasure.
TopMed Talk.
Nick Majerison here. Thank you for listening to TopMed Talk. Now, make sure you've subscribed to TopMed Talk on your podcatcher or however it is that you're listening to us at the moment. And you're spoilt for choice. We're on pretty much every single podcast platform you could think of. So make sure you've subscribed. Make sure you've engaged with us on social media, Twitter, Facebook, LinkedIn, YouTube. And make sure you've signed up for our email updates on topmedtalk.com. If you get yourself there, you'll find a website that contains all of the podcasts that we've ever done. And it gives you the chance to sign up for our email updates. That way we can always get in touch with you and tell you what we're up to. Oh, and while you're online, check out ebpom.org/meetings. Have a look, ebpom.org/meetings.